have presenters for tonight.
Let's see it all. So, hello.
Hello.
Anyone ready?
Yeah.
Okay, so today me. I'm kind of go solo today because last week I was supposed to be in the other group, but I failed in that one. Anyway, for my present today is a case analysis of the Oregon health plan, and there's two main keys today. So two main players today. Which first one is the Oregon Health Plan, and the second one is the Intercommunity Health Network. Now this guy is the big boss of the game, and the other guy is the sub-boss of the game. So I will concentrate on this guy first, and we'll give you the idea of what's the sub-boss about. So basically, some overview here. Oregon Health Plan, they are the Oregon Medicaid program, the white knight who help the poor. And they are administered by the Oregon Health Authority, Division of Medical Assistance Program. I found this kind of chart to give you an idea of what the structure of this play is. It was not really important today because we will concentrate more about the evidence-based management practice that is used in this organization. So I found this mission statement in their website that is to plan and implement medical program assuring access to basic care for eligible client. Read this table. Translate them into basic English. We got their main goals, which is the 5 things. First is provide health care for the uninsured, broad participation by provider, decreased cost shifting and charity care, a basic benefit package of effective service, and a rational process for making decision on how to allocate resource for healthcare. That's a lot of words, that's a lot of stuff, but if we translate it again into easier, simplest, is what they're really doing. First thing is that they've reformed the insurance. The description is a basic healthcare package for low-income person. Create insurance for individuals who have been denied coverage for medical reasons. I put the aha in there because we will come back to that later, and because there is something happened in their history that force them to do that. The third one, make insurance for more available and affordable, and some assessment of the new technology to the service expansion and cost containment. Next, well, basically what they're really doing is that they seek to lower the costs and provide a political dynamic for controlling costs. That's what they try to do, they aim for. And we come to the next key player of our presentation today is the Intercommunity Health Network. What they are is that they are created in 1994, and they are one of the 14 community plans that remaining. We will come back to this later too when we go over the history of the OHP. This IHN, they are integrated with the Samaritan Health Service, and they cover 15,000 OHP clients. They also provide specialty service such as the neonatal intensive care and organ transplant by linking with the other hospital. And what's special about them is that their board members include physicians and community members, key leaders of the Samaritan Health System. That system is combined with the 5 hospitals in the area, so it's really big. And one thing that worth mentioning is that they accidentally use evidence-based into clinical and business decision. Accidentally mean they did not even know that they are using it, but they are using it. So let's just what's important about these IHN is because the way they're using evidence-based is determine the strategy in OHP, and what we study as well too. So I will come back to that later. Now just take a look at the foundation. I create this chart of the history of the OHP because when I reading the case study, it was so confusing for me. The history is kind of going like back and forth, so it may be better that we're looking at a straight line like this. So as 1980, the idea was first developed in the face of a rapidly growing state Medicaid budget. And that's when the idea of OHP just first come out of the mind, but it's really not really working. And now 7 years later, somehow the Oregon decide to discontinue the major organ transplant, and that leads to the death of a 7-year-old boy who got denied a bone marrow transplant. And this really bring fire to the public, and the public really flaming them. So then 2 years later, they proposed the idea of an old Oregon health plan in 1989, when the Senate Bill 27 is passed, because they say like, well, okay, we need to change it because there's a lot of things going on. And in this years, like there are literally around 31 million Americans without health insurance coverage. So, which makes that 2 years later, they submit a waiver to the Healthcare Financial Administrative, and then this got accepted 2 years later in March 1993. And in the end of that year, the final waiver was sent, and it became law in the next year, 1994. So in 1994, then the Oregon Health Plan is really born. They really got the name from it. They really come to life. 2 years after, things going really well for them. I kind of call that the golden years because they got like 373,000 enrollees, and things really go as what they planned. So it's good for them. However, then the next years, kind of big bummer for them. Oregon economy crisis. Bunch of people lost their job, unemployment rate goes skyrocket. They lost the state lost the revenue. So the OHP people need to tighten the eligibility requirement and reduce the number of covered service. And 5 years after that, they come up with some new idea, which is, well, they say, hey, let's just find a new way to reduce the cost. So they come up with this idea of splitting the OHP covered by two ways, like one is a plus, one is a standard. The plus one is the regular one, the original one, and in the standard cover, people need to pay more in co-payment and monthly premium fees. And in 2006, all the commercial insurers in Oregon dropped out the OHP, only leaving the 14 community plans left to serve all clients. And IHN is one of these 14. That's why it makes them so special about that. So, and in this state right now, OHP have only 371,000 enrollees, and 90% of them is in the OHP Plus plan, the regular one, and only like 21,000 stay in the standard. So I don't think that why they keep that standard there. It's kind of pointless for me. Well, however, this brings us to their current problem right now. Is just basically they are really tight on budget, and they need to find a way to increase the budget. So let's just go to the good old SWOT technique, just analyze them, dissecting them. What their strength is, I think that their idea is good. It's an idea goal. You know, have more insurance for more poor people, broader. It's a good society values too. And they using evidence-based in different practice and situation, and they really have a logical practice. For example, the IHN have like the board meetings every month when people can sit and discuss in a friendly environment. At least it sounds good on the paper. And yeah, just as I said, they have good positive environment, so it could be their strength. However, we have a lot of weakness that I think is kind of not really going well. First of all, is the number of uninsured people is really high. It's still really high. And I found this chart and this number right now, it's that the number of the people is still around 600,000. And the Oregon is up here. And this is the United States. The percentage of Oregon is still kind of high compared to the whole state in general, the whole nation. And the third one is limited resource, straight out from the book. Really, they're really going low on budget. And in the case study, they said poor communication between clinical and health plan, which is what I'm saying, like the IH, within the IHN, they said they have a good positive communication, but we don't know about in the other plans, right? But, and this last two of them, it's my own opinion, I think that the OSP standard is kind of pointless, because when they first created it, people just drop out from that and go straight to the plus. And then the third, and then the last one, for me, I think the case study is kind of one-sided result. I don't see the negative things that they are showing in that. I have to look it up on Google and search it out. Everything that's talking, no, not everything, the majority of things that talk in the case study was sort of positive and talking a good thing about the OHP. So it kind of hints to them in a certain way. And now we come to the threats. Well, first of all, the economy is really unstable. And next thing is that they've got really involved in political. When I read the case study and the history part, I try to stay away from the politician part because it's kind of confusing me. And for me, I think the politics change all the time. So if you get really involved into politics, when they change, you have to change also. And the next thing is that the employment rate is still really high in Oregon. 8.4%. I found the chart in Google, and we can see that the Oregon state of percentage of unemployment in Oregon is really high compared to our state, and especially compared to the North Dakota, South Dakota, North Dakota.
Population differences.
And population different maybe too, but you know, still they really high.
Yeah.
And if I put the charge of New York in here,
Yeah.
they stay pretty much the same with New
Yeah.
York. So
Yeah.
it's one of the threats.
Yeah.
Because more people unemployed, more poor people.
Yeah.
Right? And the lack of community plans. There's only 14 left to cover the whole state. That's a big thing.
Mm-hmm.
And there's many restraining force, which is talked in the case study. There's a bunch of things going on in there. So let's just think of something more positive. Let's just see the opportunity that they have. First of all, the evidence-based management and evidence-based medicine can well develop these days. We can integrating them into better practice. So there's a few of opportunity for them. And then the second thing, well, for me, I think it's a nice try to come up with a new plan, even though it didn't really work out. I read this report saying that the number of costs that they try to reduce, but not really significant in practice. And the second thing is that we all know the number of people who got uninsured is still really high. So, you know, it's a good thing, good way to think and try to change.
Mm-hmm.
But just like Mary said, it's a good thing to change, but if things doesn't go well, it's a good thing to try anyway. So let's just go back to the AHN and the business level. The strategy in the business level. For me, well, what wrote in the case study is that the IHN people, they share the practice between plan monthly to discuss about quality improvement issues and developing the new quality improvement QI process. And then they're working with different community partner, you know, inter-community, so kind of go with community for sure. Participate with community coalition, partner with different program like the chronic care models, regional maternity care, you know, take care of the pregnant woman, etc. And do environmental scanning. Then the next thing is strategy in the corporate level, what their goal is, their long-term goal. First of all, they really want to improve their service supported by evidence-based, like the case management service, the chronic care support program, and they really want to educate their members. One thing I read about the OHP enrollee is that not many people understand what is going on in there. Not many of them know what they are covered, how they got covered, what should they do when they got into that kind of insurance. So it's really good for them to better educating them, the members. And then improving the regional outpatient quality improvement, the clinical people, and we'll coordinate and develop the quality improvement as well as keeping what's good in there. So, you know, just some things that they want to aim for. And so lastly, some recommendation. Well, I'm not a really professional, so I just pull out some stuff that I read online, and there's some stuff that I can think of too. So there is maybe things that I really need help to explaining them, because when I'm reading them, not really I understand them truthfully. And to make it in short, what I think what they need to do is to find more money, to reduce money, what they, you know. So straight out from the blue is that they need to further develop the EBM strategy, evidence-based management, evidence-based practice. Think evidence-based. One thing is that they can try to combine the evidence-based medicine and evidence-based management to find a better way to reduce the cost and medicine that is used. So, you know, reducing cost, and they can apply some of the stuff that we just learned a few weeks ago in managing hospital staff, you know, to reduce the cost as well. And then the next thing that we have, they can try to implement the co-payment in the OHP Plus plan, because when I read, like, for example, we have 380,000 people and they don't have to pay the co-payment charge. If we just charging them for like $10 something, it generates money too, so it's worth to think about it. And then here's some professional idea. They said they could try some different program. I really not got a good idea of these things. I have to write them all down in here. There's a lot of work to read. Bear with me. They said that they might try a program of health saving account that makes the insurer more sensitive to expected costs and benefit of healthcare services. It may balance spending on the preventive care in the near term against the possibility of spending on acute care in the future. So what that really means is, I don't really get it. Well, something sounds cool. And then a program offering health-saving accounts to Oregon Medicaid eligible might meet many of the goals of the Oregon health plan at a lower cost with smaller demands on administrative. Sounds big too. And then one thing I can think of is that they can try to learn from other states. Our state, for example, because we're so cool. Actually, South Carolina has tried this kind of model before. So Oregon can learn from them what is the challenge, what is the success to implement in their old program. And last of all, if everything's failed when it's come to an end, then they can always try to hit the reset button, decide to change. If it doesn't work out, and just screw that, go back. It might work the way the plan before might work today, you know. You never know. So in conclusion, well, this, as one more time, is a nice try to change, but I think that they got some really good idea in there. They got really some good application of evidence-based in IHN, in small scale, and in OHP as well. But, well, too bad for them, it doesn't work out for them because of many reasons. Still something worth to study about. So, okay.
Did it show anything other than the IHN network? So and the Oregon Health. It didn't show any of the other groups, right?
No,
it just told about these two.
Yeah, they just focus on this plan, so that's why
Okay.
I'm trying to pull them out, like the key players in there.
Okay.
Any question?
Are there recommendations from those who read this manuals? I know a couple of you did.
Well, they're, to the point that you were talking about with the savings account, one thing they were focused on doing was educating the enrollees not only about what's covered, but just trying to stress preventative care with them, since preventative care is so much cheaper than acute care. And I think that's what the point of that first bullet is that if they understand where their dollars are going and compare preventative care costs to acute care costs, they'll very quickly see how expensive acute care is.
Okay.
And then maybe be more compliant patients and do well checks and develop a relationship with a physician.
Which is the way the Affordable Care Act is taking a lot of, health plans or organizations.
Yeah, even offering free preventive care to a lot of people.
So yeah, what just kind of like.
This is a Medicaid program that also has where the patients can actually pay a premium also?
There was the two
Yeah.
plans.
There's
one-
two plans, the
Yeah.
plus is the regular
Yeah,
one.
okay.
Then they cut him thinking that, well, we should got the standard one, and then people go into standard and they all drop out.
Okay,
The
Yeah.
one had a, was for far below, federal
Right.
poverty level, then there's a higher grade one for people who could afford a little bit more, they would have a
Right.
co-payment and
Okay.
generate some income for the
so
program.
that's interesting that there's not a lot more Oregonians getting on that plan then, that could afford something that if their companies aren't giving them any kind of insurance, that they wouldn't jump on this unless you've got more poor, really poor than that.
Aren't there financial restrictions though, just like any other Medicaid plan, that even if they don't get offered insurance,
Oh, well,
wouldn't they fall into that?
there is a
If they make
number.
a higher income, fall into the
There-
COVID one, wouldn't they?
Yeah, there is a
Restrictions
number of
to have to have children.
170% below or above the poverty range or
Okay.
something. Yeah, it's in a case study, like they can raise it up to that level, but then after the economic crisis, kind of go down again. And the golden age was 1996, and then everything go out, and then they kind of screw up the whole plan. So that's
Well, it's interesting that the good plan that they're showing here, that those are Samaritan hospitals, which, when I lived there, they were one of the best hospital systems. We had Kaiser Permanente and, some other, private hospitals there. But, Samaritan had one of the best hospital systems going when I lived in Portland. They were right on top of things. So that's really interesting.